right. Well, welcome. Hello and welcome to all our viewers this evening. On behalf of Roanoke College, I welcome each of you to the series NOKELive from Washington, D.C. It's Healthcare Night. My name is Brian Parsons, and I'm Associate Professor of Political Science and the Chair of the Public Affairs Department. One of our co-hosts this evening is my colleague, Dr. Shannon Anderson, who is Associate Professor of Sociology and Coordinator of the Public Health Studies program here at Roanoke. This event is co-sponsored by the Office of Alumni and Family Relations, Sociology and Public Health Studies, and Public Affairs. Before we get started, please know that each of you viewing via YouTube can use the chat feature to ask questions of our presenters. Once the presentation is complete, Dr. Anderson and I will select and ask as many of your questions as possible. Tonight's event is being recorded and will be available on this YouTube channel for future viewing. A link to our past NOKELive events, as well as other online content, can be found on the Alumni Hub at roanoke.edu/alumni. This evening's NOKELive topic is healthcare on the Hill. And this is part 3 of a series with Dr. Rodney Whitlock, a Roanoke College graduate from the class of '87. Dr. Whitlock has gained over 25 years of experience on the Hill, working in both houses of Congress in the area of healthcare policy. During his tenure, he managed the Patient's Bill of Rights, served as the lead Republican staffer for Medicaid legislation from 2005 to 2010, and helped staff Republicans in the Senate on such prominent and important legislation as the Deficit Reduction Act, Tax Relief and Healthcare Act, the Children's Health Insurance Program Reauthorization Acts, and the Affordable Care Act. For the last 20 years, Rodney has been an adjunct faculty member at the George Washington University Milken Institute School of Public Health in the Department of Health Policy and Management, and the Graduate School of Political Management in the Department of Legislative Affairs. It's now my pleasure to turn it over to Dr. Rodney Whitlock to begin tonight's presentation and introduce our guest.
Well, thank you all for having us back here. This is the third in a series, and previously we had my friend Seth Gold, who is a staffer for Rob Portman of Ohio, and we have another Ohio connection tonight, Carlos Jackson, who claims Cleveland, the Browns, the Cavs, and even occasionally the, what do you want to be called next? The Spiders? What's your preference? You know, we do.
I go with Spiders
all the time.
I'm rooting for the Spiders.
You want Spiders too.
Yep.
So, you have spent time on the Hill. You did worked with the American Hospital Association, the Cleveland Clinic, and now you are with the America's Essential Hospitals. And so we're turning tonight to get a perspective of somebody who represents the provider space. So let me start here with this, Carlos, as sort of an opener. So you spent a lot of time in the hospital space. So, for people who don't understand how necessarily providers and advocacy connect, I mean, start by talking about just the nature of hospitals, and then how interacting with government becomes something that's important in the day-to-day functioning of hospitals.
Great. That's a great question, a good way to start. And let me just start off by saying thank you again for the invitation. I'm really, really happy to be here. I was looking forward to this moment, so glad to be with you all. In terms of hospitals in advocacy, let me just start a little bit about the hospitals in general. We all recognize the big blue sign with the H. The H letter, the white letter in the middle of the blue sign for hospitals. Unfortunately, we've probably all had experiences one way or another with the hospital. There's a lot that goes on. Hospitals are the provider of care. Anything that is happening from a healthcare standpoint in the community, you can typically go to your local hospital to try to figure out what's happening with you or a loved one. Whether it's a small rural hospital or maybe it's a large urban hospital, you can walk through the emergency department doors, if there is an emergency department, and find someone who will try to help you. So we understand hospitals as a setting of care, but if we also think about all the different operations that are happening within a hospital setting, There are many different people who are employed by hospitals, anywhere ranging from the size of a hospital, from the hundreds up to the tens of thousands. As Rodney noted, I happened to work for a hospital that had a number of employees in the tens of thousands, Cleveland Clinic. So when we think about the operations of providing care, and then also just the hospital itself and the role it plays in the community. Yes, are the provider of care. Yes, it is in a place of employment, but is also a place of education. It is also a place where someone who just needs any type of help can get that help. The emergency department doors are open to anyone. So if there's someone on the street who is hungry, walk into an emergency department doors, they can be fed. If it's someone on a cold winter night, again, that is also homeless, looking for a warm place to feel a little bit better, walk through your emergency department doors. These are some of the different things that are happening on the day-to-day basis in many of the hospitals around the country. So when we think about what I just mentioned and apply it to a government setting, there are certainly a lot of regulations and laws that are in place to allow for that care to be provided. We also think about it in the context of some of the government programs when it comes to healthcare. We have Medicare, the federal program for those Americans over the age of 65 to be able to have meaningful health coverage. If you are a Medicare patient, you can go to your hospital and get care. We also think about Medicaid, which up to a certain point in time was really considered the healthcare coverage for those who are less fortunate in terms of their means. But there was a health reform law 10 years ago, or a little bit over 10 years ago, that has since changed things a bit. And so Medicaid has been expanded in terms of those Americans who receive coverage through that program, including some who receive coverage from other health programs in addition to Medicaid. So when we think about bringing all those elements together, provider of care, an employer, provider of certain essential services, public health functions, and then having also government healthcare programs, you can see the intersection between a hospital and why it's important to have a government role in the operations. And then from an advocate's perspective, also in terms of communicating, engaging with government to determine what is helpful in terms of government interactions with healthcare in areas where it's not quite helpful, where things can change. I hope that captures your first question.
It's a great opener, and it really does allow us to sort of talk about the hospital space is unique in terms of the advocacy space because you have the straight up healthcare issues where you're dealing with at any given moment all of the payment issues involved. But you also are getting into spaces of labor issues, and certainly you see that with the in the space of education, where you're talking about being part of a graduate medical education system. I mean, there's a huge variety of issues that hospitals deal with, not the least of which is being ground zero in the middle of a pandemic and how challenging that is. Can we use that sort of as a obviously we're not saying anything we're not allowed to talk about here, but how hard it has been in this space in this last terrible year for us to try to advocate the challenges that our members are facing?
That's another great question. And just to give a little bit of background behind that, again, I work for America's Essential Hospitals, so we are the trade association for essential hospitals, as we like to call it, or call them, but really think of it as the safety net hospitals. So those hospitals that sit at the heart of the safety net for communities. So when we think about the pandemic that we're living through, COVID, number one, is unprecedented. In our lifetimes, yes, we've had some infectious diseases that have, hit our shores or brought higher rates of infection for certain viruses and brought more folks into emergency departments and also, unfortunately, deaths, but nothing to the level of what we're experiencing today. This is our bubonic plague. This is our this is our flu, Spanish flu from 1919, and we're living through it now. So it's been pretty unprecedented for our lifetimes. So when we think about this current pandemic, and again, the organization that I work for, hospitals that are serving the healthcare safety net, this pandemic is hitting those Americans who can't really afford to stay home and work from home, like I've been able to do, like Rodney has been able to do for much of the last year. Many folks still have to get outside of their homes and work and bring home a paycheck and pay the bills. So for those essential workers, for those who are living in multi-generational housing, you have grandma and grandpa and aunts and uncles and others, and, under the same roof where social distancing is not easy. These are the same folks who are also walking through the doors of many of the hospitals that my organization represents. These are the folks who are walking through the doors before COVID in thinking about the spread of this virus. These are certainly the folks who have been walking through the doors during the COVID-19 pandemic. So from our perspective, this pandemic has been a major disruptor in terms of the ability to provide adequate care, particularly those who still need to go to the hospital for care that has nothing to do with COVID. Doesn't mean that heart attacks have stopped, or car accidents or any other traumatic events over the past year. Those things are still happening. So for a hospital perspective, you're dealing with a major unprecedented infectious disease that is spreading rapidly throughout communities, infecting many individuals, infecting families, bringing more folks into the hospitals for that condition, leading to many more deaths, as we all know, but at the same time, still being able to try to provide that normal course of care in everyday life that, things happen thousands of times, tens of thousands of times every day across the country. So that has been quite the challenge of dealing with this major infectious disease event while also trying to still provide care, but also at the same time having a major disruption to your operations. Those caregivers within the hospital that don't need to be there, they should be at home. But if you're taking folks home, then you're also shutting down certain operations within the hospital to just those essential services, which again points right back to COVID-19. So been a major disruptor for many of our member hospitals, unprecedented in the strains that it has placed, not just financially, but then also on those caregivers who are living and working through this, just enormous. I think we won't really fully grasp the full impact of this until maybe a couple of years after this virus goes away.
And our members, the hospitals, the American Central Hospitals, that the patients are coming. The people in need are showing up in the door. And it's not as though you get to pause and try to figure out what the right way to deal with it is. We're trying to get as much as possible information from the government, who is also CDC, NIH, who is also trying to figure it out. I mean, the pressure that creates in the space is just brutal for us. I mean, on the advocacy side, to try to reflect back to Congress what our members are dealing with and how challenging that is. I mean, and be able to talk some more about that.
Yeah, it's the work that Rodney and I do, most of our days, every day of the week, it's a lot of hurry up and wait. You will hear that term a lot in the advocacy space, but when you think about in a hospital setting, when folks are walking through the door, there's no such thing as hurry up and wait. Yes, when you're a patient, sometimes you may feel I'm waiting in the emergency, department, in the waiting room. Come on, let's get going. But from that caregiver's perspective, they are trying to figure this all out on the fly, and then also provide a measure of comfort to those patients and their families who are walking through the door, all while you're still trying to figure this out. And from the government perspective, they were doing the same thing. Major pandemic, basically crippling the entire economy. Every pretty much part of the economy of this country has been touched by this pandemic. And how do you figure all that out when, for most parts, from an advocacy perspective or even legislating perspective, a lot of it's hurry up and wait. There was no time to wait. You had to figure it out on the fly. So that was a major challenge to say to government, here's what's going on. Here's what we need today to be able to get this done to help patients tomorrow. We'll figure out next week too, while we're in the middle of this, and then we'll look down the road to 2 or 3 months from now. But the challenge was trying to communicate what needs to happen today with a virus that we could not predict the spread, particularly how quickly it spread across this country. And I think for any of you who go back to see the number of infections in January, in deaths in this country, infections and deaths related to COVID from January to February, not very many. And then you see explosion in March. And then you think about where we are today. Major scale, a massive amount of thinking of how do you care for populations in your communities without also spreading the virus within the halls of your hospitals. And by the way, tell government how you can figure this out while also dealing with all the different regulations that are in place for regulating hospital operations.
So I want to talk a little bit about the term safety net and safety net hospitals and who we are. Because within the hospital community, and you've worked for the American Hospital Association as well, there are varying types of hospitals. There are children's hospitals, they're for-profit, they're not-for-profit, they're teaching hospitals, Catholic hospitals. There are many flavors of hospitals. But what makes America's Essential Hospitals different? I mean, what is it about the communities that they serve and where they're located, and that really distinguishes who AAH is, America's Essential Hospitals is, and what the mission is?
Yeah, that's another good question. I like to think of this in kind of more of a pop culture way. So I'm someone who grew up, I wanted to be a doctor, just full disclosure. So I went to college with the thought of being a physician. And I was a kid who loved going into hospitals every day and just didn't mind getting shots, whatever. I just loved being in hospitals. So I loved hospital TV shows. So for me and Rodney, we're of certain ages. We can remember Trapper John MD or St. Elsewhere, shows like that. ER for those in the 90s. But if we think about it today, it's New Amsterdam. So when you think about those hospitals on TV shows, they're always showing the safety net hospital. If it's ER for those who watch reruns on cable these days, ER, that hospital is basically Cook County Hospital in Chicago. Cook County is one of our quintessential essential hospital members. We think about New Amsterdam, the new show, that is actually one of our member hospitals. That is supposed to be Bellevue Hospital in New York City, not Bellevue. I think I might getting the name mixed up, sorry, but it's one of our core member hospitals in the New York City area. And one of our members is New York City Health and Hospital Corporation, which is the system of public hospitals across the 5 boroughs of New York City. So if you watch New Amsterdam on NBC, which was on last night, you see the different stories and challenges of that hospital. These are our members. We are the hospital that the community turns to in the time of crisis. Again, whether you're hungry, whether you are sick, whether you are in a traumatic accident, we are the level 1 trauma center. We're the ones who open our doors and allow anyone to come in. You're all welcome. We provide high level care, but we are the safety net provider for the communities that we serve. So think of any and all being welcome through our doors. And we also see many of the patients that can give you a good cross section of all the different factors that are influencing a given community on a given day. Whether there's a spike in crime, whether there is a hunger crisis, whether there's an environmental issue, whether there are substance abuse issues or drugs hitting the street and there's a pandemic of overdoses. We see all of these things on a daily basis walking through the doors of essential hospitals. We are the essential provider for that community.
I'm reminded one of our members taught me a phrase, also somewhat famous from a TV show, Grady Memorial in Atlanta. And I've asked them, they said, if I visit them sometime, they will show me where they keep the zombies if you're a Walking Dead fan. Grady uses the phrase, we keep Atlanta alive. And so it's that connection that they have to the community as the community provider that our guys have, and that's the way we look at them in their role. Which is not to say that it's not speaking comparatively to other hospitals. It's just their role versus the other flavors of hospitals. Fair?
Indeed, definitely. We are there to keep everybody alive and keep everybody well and healthy and well.
So with that, turning to more of a policy specific and talking a bit through process, and the congressional side of what we do, all hospitals get paid, and how they get paid varies a lot by the type of people who walk in the door, and who pays for their care. So we, America's Essential Hospitals, are folks whose payer mix is geared towards government payors. Can you talk a little bit about that, Carlos, just how that then makes a difference for how you approach the whole concept of government funding as to who your payers are? And you feel free to use our friends in Dallas as an example, because goodness, that's one of my favorites.
Yes. And Rodney's mentioning Parkland Hospital, Health and Hospital System in Dallas, Texas. That is also known as the hospital where former President Kennedy was sent. after he was unfortunately shot back in 1963. But that is a perfect example of a, at least at times public hospitals, but a safety net hospital for the community. But for our hospitals, as I noted, we are the hospitals for all people. So we're the hospital that everyone is comfortable turning to in the time of crisis or a time of need. And so when we think about it in respect of who are the demographics or what are the demographics of the patients that we treat, yes, we are going to see a fair number of Medicare patients. Again, government coverage for those over 65. We're going to see a good number of patients who have Medicaid coverage. And we're going to see a smaller number of patients who have commercial coverage. Commercial being, your employer provided insurance covers that either you or your parents will have for the most part. So when we think about communities that we serve, the demographics of those communities, the income levels of the folks who live in those communities, yes, we're very dependent upon government coverage. And since patients are walking through our doors with that Medicare card, so to speak, or having Medicaid coverage, it is the government that is paying us for providing that care. So, but the interesting part of this is that when we think about government healthcare coverage, the payment that they are providing healthcare providers for, extending a service is often going to be less than the cost of that care. So if we have a patient mix where we have 25% of patients who walk through the doors having commercial coverage, and keep in mind that commercial coverage will oftentimes cover the cost of care. In some cases, sometimes a little bit more than that, but that's a whole nother story. And then we have, say, another 35% of patients who are walking through the door with, say, Medicare coverage. So we've got some patients who are coming in, good number, who are, the payment back to the hospitals being less than the cost of care. And then we have, I have 35 and 25, so I'm doing my math here. So we're at 60. Yes. So then let's say we have the remaining, I'll say 35%, because I won't do this up to 100. I'll do it to 100, but 35% will be Medicaid coverage. Medicaid is typically even I was going to use the word poor, but that's not fair in this context, but they pay worse than Medicare does. If Medicare is providing care and they're paying us 91 cents on the dollar for that care being provided, Medicaid on average is paying us about upper 70s to about 80 cents on the dollar for the care that's being provided. So the point being, if you have, in this case, I had 40, 35 of 75% of the patients walking through the door have government coverage, in each dollar that's being paid by the government still is not covering that cost of care. You see the deficit here.
Mhm.
It's pretty straightforward math, and that's what our hospitals experience. They have really thin margins, and we are, again, very dependent on that government coverage. We don't want to see it, or payment, we don't want to see it cut, but keep in mind, it's not like we are bringing in a ton of revenue that makes our hospitals profitable in that respect. Even though we're talking government hospitals and nonprofits, you still need to be able to fund your operations.
The federal government, though, recognized what you said by creating something called disproportionate share hospital payments. And these are payments that hospitals who have a disproportionate share of Medicare, Medicaid, and the uninsured get a special add-on payment to help make them whole to address that, which is a good thing until those payments were cut in the Affordable Care Act. Actually, the Healthcare Education Reconciliation Act that followed it, but not that I'm being picky. But there was a theory that said the more people get covered through private insurance, the less DISH is needed, so we can cut DISH. Hasn't completely turned out to be the case. So we've had to then fight Congress to not let those cuts go into effect because of the harm they would do, to the safety net hospitals. So talk a little bit about the work that that you've had to do on behalf of AEH to try to make sure that we didn't see additional payment cuts, and particularly the lobbying and all that, because that's sort of where the advocacy comes in, protecting the members.
Yeah, this is a great question. And I'll just start off, but bear with me by noting that this is the 40th anniversary for America's Essential Hospitals, our trade association, which used to be known as the National Association of Public Hospitals, and then eventually National Association of Public Hospitals and Health Systems. But we were established in 1981, and we were established on the back end of legislation that was passed, which actually introduced the concept of disproportionate share hospital payments, these supplemental payments for providers that are providing services to patients who are of lower income, basically underserved patients, if you will, and then all the extra care that goes into treating those populations. That's what the DSH payments cover. So if we think about the health reform law of 2010, this notion of expanding access to coverage thought was, hey, more folks have coverage, there's less of a need for DSH, as Rodney explained. But we know some things that you dream, that you write on in concept on paper, sometimes doesn't come to fruition. So the coverage expansion that was designed, that Rodney actually was very close to back in his time on the Hill, didn't come didn't happen. So this notion of cutting payments to hospitals that are serving patients that are dependent on either government coverage, Medicaid specifically, or they're uninsured, then there's a tension point here. How can we cut this supplemental funding that frankly helps our hospitals stay financially stable when the coverage expansion that was thought to be guaranteed in the Affordable Care Act health reform law did not happen? And I will note that part of that was that Medicaid expansion, which was a good chunk of the ACA, which was to be mandatory originally in the law, was determined in the famous Supreme Court case back in 2012, Rodney, or
2012?
Yeah, 2012, determined to be unconstitutional in terms of making it mandatory, because Medicaid is a joint federal state program. The federal government cannot coerce a state to do something in exchange for getting Medicaid funding. That was essentially what the court said. I'm not a lawyer, but that's kind of layman's terms. But so we've been fighting every year since 2014, which is when the cuts were to go into effect, to keep them from happening. And Congress, thankfully, on a bipartisan basis, understood our concerns, because it's pretty elementary with the way I explained it. Coverage was not expanded to the levels that everyone envisioned. So the notion of cutting back on supplemental payments meant to subsidize providers who are treating those with less coverage. You need to kind of push that off for a while. So every year we would have to go hat in hand to Congress and say, please do not implement these Medicaid DSH cuts. The problem is that every year that we were successful in preventing these cuts going into effect was that they grew.
Yeah.
So what were $18 billion worth of Medicaid cuts back in when the health reform law was signed into effect, it eventually grew to be $44 billion worth of Medicaid cuts. Thankfully, we're now to the point where we've worked with Congress to be able to start knocking down that $44 billion price tag of the cuts. We're now down to $32 billion. That's still a lot more than 18. And we still know that there are many, many Americans who have lost their health coverage since 2010. And unfortunately, because of the last year and the pandemic, those numbers are going up.
So then we end up having to go to the Congress. This has been a priority to try to get Congress to extend that. And so it's the nuts and bolts of trying to get into bills, into moving vehicles, getting the members. I mean, and that is, I mean, you have to motivate the members and when I say members, the member hospitals to do their job. It becomes part of an advocacy strategy, which you're in charge of.
Yes. And trying to find the arguments, again, for getting the policymakers on Capitol Hill to pay attention to us. Again, hey, you said we would have 85% hypothetically of Americans covered, but really the number is more like 70%. How does this impact the hospitals that, again, are already scraping by with the thinnest of operating margins? Again, we're dependent on government payers, and government payers will typically reimburse us less than the cost of providing that care. So that's been really one of the main arguments in working together with our member hospitals, to Rodney's point, is actually translating to, folks on Capitol Hill. What does that actually mean on a day-to-day basis? So what does a Medicaid DSH payment and a cut to Medicaid DSH payments mean for the average person every day walking through the doors of the hospitals? Why should they care? And why should the lawmakers care? So really the work that we do is helping to promote those stories on Capitol Hill on a daily basis, being the DC representative for our member hospitals. But then the advocacy coming from our member hospitals are extremely important, because they can share the actual financial impact for that hospital, what it will mean for the communities that they serve, and what it will also mean for some of the services that are offered to those communities, especially the services that are offered outside the walls of the hospitals, because there is a lot that goes on to try to keep folks from coming to the hospital if they don't need to. If you're coming into the hospital because you have asthma and you don't have a primary care relationship with a clinician, then it's not the best to be walking through the emergency department doors every day, or sorry, every time you have an asthma attack. That's more expensive for the patient. That's more expensive for the healthcare system, not the system, the hospital system, but the overall healthcare system, including government overall. So we share those stories, advocacy stories, when we are trying to prevent things like these cuts from going into effect.
And we won. We've got a delay for 3 years, as I recall,
Yes.
in a deal struck in December. So that means maybe we can advocate on some other issues like social determinants of health, social influencers. Think about sort of being able then to talk about something like that instead, and how we could use that role to try to be positive within the community.
Yeah, and that's an area where COVID actually is a good starting point for the conversation. I mentioned at the very beginning of this that COVID-19 has disproportionately impacted the communities that our hospitals serve. Again, higher rates of infection, higher rates of hospitalizations, and unfortunately higher rates of death are hitting the populations that really turn to essential hospitals when they need care. So when we think about those factors I just mentioned, why are there higher rates of infection? Why are there higher rates of hospitalizations and death? And it gets back into some of the basic underlying health conditions that exist in many of the communities that we serve. And some of those underlying health conditions, like, okay, why the higher rates of diabetes? And we see that folks with diabetes, unfortunately, aren't doing so well with COVID. Well, they happen to live in a community where there's a food desert. Instead of going to the local grocery store to get, a well-balanced shopping cart full of food, they're often going to maybe the corner store or subsisting on fast food, which obviously has an impact on health. So when it comes to public health emergencies, you can already kind of pinpoint where some of the populations will be worse off, so to speak. So if we want to address this and keep it from happening again, then you need to turn the conversation back into advocating for addressing some of those social factors or social determinants that dictate a person's health. And so that's where COVID-19, unfortunately, has once again shined a spotlight on the different socioeconomic factors that will impact someone's health, whether it's, not having a car, having to rely on bus transportation to get to work, but then again, being in a closed space in the middle of a pandemic with some people who frankly won't wear a mask, you're setting yourself up to be infected. So that's where some of these issues come into play today.
And again, in many communities, hospitals are the largest employer. They play a keystone role within the community. So, taking on an opportunity here to try to change that is something that our guys are willing to discuss. Fair?
Yes, it is. We are, in addition to being the focal point for care, just being the largest employer, we have a voice. We have a voice in the community. There are also certain responsibilities that come into that. And I'm not thinking about, necessarily responsibilities related to government and payment, but there's still a responsibility period of being a leader. So when we talk about clinicians, and frankly, there are a lot of brilliant clinicians, no matter what hospital doors you're walking through. I guess maybe because I'm not a doctor, I'm sitting here as a lobbyist talking to you. Clearly, I wasn't smart enough to make it. But for those folks who were, who are smart enough and were smart enough to make it, these are the folks that you really want out front, talking about some of these issues and what needs to be done to prevent further spread of this unfortunate disease, this virus. So you do have that responsibility, not just being the respected provider of care, also being a large employer with a large voice for that reason and a role, responsibility reason. But frankly, we are also many of the folks within our hospitals, they are, I hate to say the word expert, but these are the scientists. Yes, physicians can be scientists too. In that regard, not just a responsibility as an employer, there's just also that basic responsibility of providing some of the scientific fact that needs to go along with it. I know I kind of went beyond your question, but
no, that's really, talking about the complex role of hospitals within the system. So as we've done these previously, because of the diverse nature of our audience here, from alums wanting to talk about healthcare to students taking healthcare, to then those who just sort of want to figure out, okay, what the hell am I going to do with my life once I get a degree? I'd like to pivot a little bit to talk about your pathway, how you got here. So I didn't do a very deep introduction because I want you to sort of then now use this part to talk about, okay, you and I know that you were in St. Louis for a while, went to University of Missouri, and okay, how do you get from there to here in your life? And what were those things along the way that influenced you, and helped you become who you are today and what you're doing today?
Rodney, I was a nerd as a kid, so instead of having Hollywood dreams, I had different dreams, and wasn't going to make it on the West Coast, so might as well, thought about going to the East Coast. No, I was a political junkie as a kid. I actually had three passions as a kid: sports, science, believe it or not, and like politics and history. I loved studying that stuff and reading it. So as a kid, I was very much into politics and following campaigns, and I loved history class and reading up on different forms of government, not just for American government, but also international. And it just fascinated me. And as someone who likes to observe people, that is, politics and the policy that goes along with it, is really a lot of sociology and psychology in some ways too. So I think I just had all these interests in, I really, the science part of me really drove me wanting to go to med school, be a doctor. And again, I figured out in college that wasn't really the pathway that I wanted. But I did kind of fall back on this love of government and this love of politics and studying those subjects as a kid. And I kind of gravitated towards that near the end of my college career, actually, and got a minor in poli-sci, which actually kind of put me on this pathway. And it was having a friend when I was in college whose dad was the lieutenant governor of Missouri, who also got me on this pathway. He eventually became the governor of Missouri when a tragic event, when the sitting governor who was running for Senate at the time, U.S. Senate, he tragically passed away in an accident. And my friend's dad became the acting governor. But really talking to him when I would go over to my friend's house to hang out, who lived in Columbia, Missouri, which is where University of Missouri is located, that really got the wheels spinning. And I eventually determined that I wanted to try to give this a shot. And I did try to get involved locally in Missouri, in the St. Louis area, after I graduated from college with the help of the then lieutenant governor. And but eventually I was always looking at DC. And I was one of those many people who just packed up the car and drove out here with no job. I did have a couch to sleep on. So that was my hey, I have money saved up in the bank and I'm just going to give it a shot. And I didn't know anyone. And I thought I could do it on my own. But long story short, it took one of my best friends from college, whose dad was in the military and stationed at the Pentagon, who introduced me to a defense lobbyist who eventually took pity on me and taught to me just to do an informational interview. But lo and behold, he's the person who hired me after that informational interview because he wanted to give me a shot. But that started me on this pathway that got me to DC. I didn't have this figured out, this plan, but I just knew I wanted to get here. And I guess really the lesson for this backstory is that just getting here and being active and trying to make something happen, I somehow got a career out of it that coincidentally allowed me to work in a hospital for one of the top hospitals in the country, if not world. Coming full circle in my hometown of Cleveland, Ohio, which I never thought would happen, but that is my background, my pathway. So I did have a minor in poli-sci. I did have an interest in all of this legislative process, politics in terms of political campaigns. And I think for me, my one area that I used to be a lot stronger at, but as a manager now, I still have this ability, but I love the intersection between policy and politics. And that's what I love about lobbying. You can think about the political chess that's involved in a certain situation, but I'm a detailed person. I love figuring out something, maybe because I like to debate certain things, but you can't really debate if you don't know what you're talking about. And that's where the interest in the policy comes from. I actually want to know what I'm talking about to do the point counterpoint and see if I can win. Let's face it, people in DC are also very competitive.
Yeah.
So it may not come across to most people, but I'm extremely competitive. It was far worse on the sporting field. I had a lot of fights. I threw elbows. So, sorry.
No, it's forgiven. So your first job on the Hill was Klexa. Do I recall that correctly?
Yes, Jerry Kletchka. Yes, from south side of Milwaukee. Yes, great guy.
Yep. And so, how did you get your way into that role?
So this defense lobbyist who took pity on me and hired me, their firm did defense lobbying, some other things, but also fundraising for members of Congress. And one of their clients was Jerry Kletchka, and his chief of staff used to work in that firm. So when they knew I came to DC, not just to spend my time working for a small defense and Native American, actually, lobbying firm. They did a lot of tribal work. They knew I wanted to get on the Hill. And so when Kletchka had an opening as an executive assistant opening at that in his office, I said, sure, I'll give it a shot. The partners told me, and I said, yeah, I'll apply. And, I interviewed, had never, ever had a role like that, but I figured I could figure it out. And I got the job. And I was told, actually funny, I can say this, and unfortunately, Jerry passed away a couple of years ago, but he would appreciate this. I was told like, oh no, you're going to work for Kletchka? He's difficult. One of the best bosses I've ever had in my life. For whatever reason, we got along so well that he took me under his wing. And I still look back fondly to my time in his office. But Kletchka, that's how I got started as his executive assistant. So his right-hand person in terms of scheduling and where he needed to be and who are the VIPs he needs to talk to. And then I did some campaign work. And when I did that, he called me back to actually transition to the leg side of things. And that's how I got started on the legislative pathway.
Do you, and then on the legislative side, when do you make your way to healthcare?
It was when I worked for Gwen Moore, who actually succeeded Jerry Kletchka when he retired. She represents Milwaukee currently in Congress, serves on the Ways and Means Committee, which has jurisdiction over Medicare policy, or most of it at least. Definitely Medicare payment policy for hospitals, inpatient side.
Yeah.
And yeah, I won't get into the outpatient stuff, but working for Gwen, I picked up health coverage, health policy, and I actually didn't want it, so I gave it away. Mm-hmm. I love tax policy. I did tax and trade. That was my thing. I love that. But it was actually what really got me into it was when I left the Hill and I got hired by the American Nurses Association. A friend of mine who worked there thought I would be a good fit. And so that's what pulled me off of the Hill. And then AHA, American Hospital Association, about a year after that, started talking to me and said I would be a good fit there. And I guess the rest is history from the hospital standpoint.
And then you left to go back to Cleveland. And what was it? So you've represented associations, but you've also represented an individual association. I mean, that's when you have to be for the team. And how was that being back for in Cleveland for the big team there? I mean, that's a different experience than where you are now.
Oh, totally different experience. Different parts of the brain too. Mm-hmm. It's one thing to try to think about representing the interests of an entire field, and where the entire field is depending on you and trying to boil that down into specific but yet general points to fit everybody. And then another one that has its own interests and own needs and really living and thinking about that every day. Different mindset. Also it was very helpful to be around some pretty brilliant clinicians on the daily basis in terms of what it means to be someone who is providing care, the workload that's involved with it, some of the regulatory requirements that really don't lend themselves towards actually providing care and in some ways hamper it. So learning how the operations of a hospital from a business standpoint, the operation of a hospital from a provider standpoint in terms of providing care, but then also understanding the relationship between that hospital and the community. That was probably the most important lesson learned there, was that community role and what it means to be a large employer and a large provider of care. And then again, a place that everyone turns to for answers, whether healthcare or not.
Yeah. And then now back in DC again, it just keeps pulling you back, as the story goes. You are and just one last one for fun. You are a drummer.
Yes.
You picked that up somewhere along the lines, and still, have the skins around to hit on occasion to take out your frustration with Congress.
Every weekend.
One last little factoid here before we open it up, because I just found this out today. Your wife is an Arlington school teacher, as I understand.
School psychologist.
Yes. Did you know this? That in Arlington County, the second most popular liberal arts college, that is in terms of applied and enrolled, is actually Roanoke College. I learned that myself. So apparently my new hometown, the kids apparently like my old hometown. So that's our combined Roanoke connection here.
Pipeline strong.
Yes. So, and the other thing, we're the Maroons, by the way. It's us in Chicago, just in case you didn't know. All right, Dr. Parsons, Dr. Anderson, having reached the 3-quarter mark, open the door and let you guys come in, and you can torture us with questions for a bit.
As we will do, as we will do. So this has been absolutely fantastic. And as a kid who grew up in DC, I grew up in Fairfax County, that competitive streak runs strong in that whole region. It's just part of the culture. So that makes a lot of sense to me. So we have some questions. I'm going to actually start with one and then spin it a little bit to connect more to some of your work, Carlos. So there's a question from Karen McLennan asking what you think about COVID-19 and its political implications for various groups who are affected the hardest in terms of the toll, and then asking where your analysis stands. And what I'd love to hear you do is take that question and think about it within the framework of representing hospitals that are serving vulnerable populations, and primarily populations that are the most affected by the social determinants Rodney was talking about earlier. So, and that you mentioned as well, living in multi-generational homes, living in high density neighborhoods, having public facing jobs. How does COVID affect these hospitals, and what are the political implications then for you as a lobbyist representing these safety net hospitals?
Yeah, no, it's a great question. Again, the story of COVID-19 will be around for many, many years to come, if not generations to come. There will be a lot of lessons learned coming out of it, and hopefully we'll learn some of the right lessons. I think one thing that's been, again, one of the main stories here is just the impact that this pandemic has had on, again, communities that have been struggling for many different, reasons. And we think back to when you think back to public health crises in this history of this country, you can kind of point to, again, the communities or the populations where the impact will just be greatest. We automatically will know. So when I think about the political implications of COVID-19, is really pointing, again, this bright spotlight on some of these communities that have been hit the hardest, but understanding the reasons why. And I think from a political and even a policy perspective, it's actually forcing the conversation to go, okay, well, why are these things still happening? There have been many smart people who have written some great policy, Rodney being one of them, but yet we still have some of these same conditions and factors that are impacting communities. And that really, when you think about it, they're a great driver of healthcare costs, frankly. So yet we're spending our way out of these problems. So I think one of the lessons will be, can we take a look at some of these indirect factors? I wouldn't even say they're indirect. They're just non-healthcare factors that drive health. Again, whether it is food, whether it's safety, whether it is transportation, whether it's employment, having a job that pays well. And if it pays well enough, then you can buy better food because you will have access to a car to get you to a better grocery store. All these things connect. So I think it is really the connecting points that are being eliminated here. And I think politically, Congress has an opportunity, and this new administration has an opportunity to try to address those connecting dots and hit these issues.
And Carlos, I want to throw one other thing that I think that is going to get discussed as part of this, that we have a payment system, particularly in healthcare, that discourages capacity, particularly excess capacity. If any of our guys have empty rooms, that's considered a failing.
Yep.
That you are supposed to dial to exactly the number of rooms. They're supposed to be in use all the time. And if you have a surge on the need for capacity, you stretch to break the net incredibly quickly. And I think that that's one of the lessons, particularly because our guys have faced it so hard when we've had these surges with the need to treat people, that we are not built to address that because that's not the way the system pays. The system pays to have you dialed exactly right, not one bit over it. And maybe that will be one of the lessons, trying to say, okay, if we have an issue, we need to make sure we got the capacity to deal with it.
I think I'll even, sorry to belabor this, but I'll make a kind of a controversial comment in that maybe some of the policy decisions that have been made in recent years that have impacted care. We think about, say, site neutral payment policy. For a number of hospital leaders for years, you think about patients who are sick, they're so sick, they're coming to the hospital, you're spending a lot of money on the cost of that care. Is it better to invest in primary care and preventive care to keep them out of the hospital in the first place? There were some policy changes that have impacted that decision-making point, but as one of my former employers said, the former CEO of Cleveland Clinic, there's a sick care model when there needs to be a well care model. And I thought that was a great way of describing the point. We wait for folks to get sick and then we take care of them, which again, from an efficiency standpoint and a cost standpoint, it's not exactly probably the most logical thing to do. We need to kind of build towards that more well care system, and some policy decisions have even taken that away. So.
Dr. Parsons.
Oh, okay. So I have, as a political scientist who's actually teaching a course on U.S. health policy this semester, and I probably have many of the students tuning in tonight. I have several academic questions that I could ask, but I'm not going to ask an academic question because I've also been a patient. And so I have a question from a patient's perspective. And it's I guess simply this: why is it so difficult to figure out how much my care is going to cost at a hospital?
Yeah, so that's the $64,000 question. Let me think of a good way of responding to this. I'm going to say this.
By the way, I hope the dean is on watching this. You mentioned it's a $64,000 question.
Yes, you might think of this as a cop-out response, but I think, we're so used to commodities and services in this country, where we pick up this pen in my hand, and we should be able to look at this and say, here are all the different units of cost that go into the production of this pen, including labor costs. And, you can even just do it on a scale here with like this much is for, labor and research development, et cetera. Mm-hmm. When it comes to healthcare, is it that straightforward? Mm-hmm. Not necessarily. And it also brings into question, should healthcare be like that? Is healthcare a widget? Is healthcare a pen? Is your body, or your mom or dad's body, or if you have kids, their bodies, this pen? And that brings in an element of emotion. So if we're trying to talk about business concepts, widgets, guns and butter to go econ 101, but we're doing it in the context of a person's human, their body, in feelings, in emotion, in pain, and anger, and all of that, this is where it all gets complicated. So I think it's just, for those reasons, it's very cloudy, it's complicated. But I think we also have this tension of wanting it to be the widget or the pen that we can break it all down and somehow ignore the fact that there's a lot of emotion in human emotion that goes into it. And then frankly, the system in this country, government coverage, Medicare, Medicaid, employer provided private coverage, and then somehow trying to apply this going on all the time. Which way is north? Are we socialized medicine? Are we completely private? We have a hybrid, and the tension collides every single day, and that also makes it difficult.
There's also the side of it where the payment model is built on discounts. And when you build a payment system built on discounts, then what you see on a piece of paper is a payment rate that nobody actually pays. You were discounted off of it, and that's what it is. And you're looking at it, and it makes absolutely no sense because it makes absolutely no sense.
Yeah.
Yeah.
And that's what makes it
well put.
Yes, indeed. So along these lines, I think one of the things that drives current polarization on everything related to healthcare is how much we don't understand, and how our system is in fact a hybrid. And for some people it works one way, and for some people it works another way. And so Kimberly McGinnis has asked the question, how would you suggest healthcare policy help overcome polarization?
Ooh, that's a really good question. And I think if we had the answer, if it was an easy answer, I guess it would have been done by now. That's a really tough question. Good question too. I think if there's a way to bring, boy, this is a tough one. I'm trying to think of a good way to answer this one. It's almost, how can we take emotion out of it?
Right.
Healthcare policy, there's some pretty good logic. I'm a logical thinker, so I keep coming back to logic, and that's a flaw. Maybe I understand it can be a flaw at times. But when you think about just straight health policy, take away the emotion, a lot of it makes sense in some ways. But again, you're bringing in this element of we're human beings. We've been hurt. We've been sick. We have loved ones who've been hurt and sick. And then things get a little complicated. And so then you start making exceptions. or you start doing something to try to compensate for, not compensate financially, but to try to, address a certain factor. And then when you start making those accommodations, if you will, then it works for one side, but then it won't work for another. And so this is where I'm basically saying this, because this is where some of the polarization starts coming into play. We think about the Affordable Care Act and the debate, and I remember sitting through this markup during the development of the Affordable Care Act on the notion of having end-of-life conversations if you're a Medicare beneficiary with your physician. Somehow that morphed into death panels. Also, PCORI, the Patient Centered Outcomes Research Institute, which was to figure out what are some of the most effective and efficient courses of care. Basically, the government getting better bang for the buck in terms of what services or things to actually put forward. How did all that get turned into death panels, rationing?
So, and
It's hard to bring that emotion out of it.
And I'll just really quickly, Carlos, particularly from the conservative perspective of wanting to treat healthcare as a marketplace, is really hard to find your way towards some sort of middle ground there, because if you can, it's just not the same. It's just not. And as other consumer goods and services, and trying to bridge that gap when the fundamentals are so different, it remains a problem for any type of common ground.
Yeah, that's it. Market. That is the best way to describe it. Healthcare is a market, and the tension is, should it be a market?
Right. And it's interesting to look at how other countries try to answer that question.
Mm-hmm. It is fascinating. It's going to be fun. Some people make it boring, but it can be fun to kind of dig into that.
We will be talking about it. We will be talking about it.
That's a good thing. We should be. So I guess along these same lines, this is another question. I'm not sure whose question it is. What, if anything, do you think would help the most when it comes to the healthcare system in this country? It's a really broad one, but important.
Yeah, I think it's, I'm going to say the word clarity. And again, you might say, like, well, what does that mean? There's so much, there is a strong need for clarity. Again, what is the mission? And if there is a mission here in terms of either how Medicare should work or how Medicaid should work, then what is it? And is it something that can be boiled down to 5 bullet points or 10 bullet points, or does it have to go on for 5 chapters or 10 chapters? There's just a need for a lot of clarity, I think, in healthcare, and that will make things a lot better if we can streamline. But in this kind of work that we do, you try to get something done. You say, but have you thought about this factor? And then you turn the dial a little bit this way. And then you turn the dial a little bit more and a little bit more and a little bit more. And that brings a lot of, doesn't make things quite clear, even though the intentions are, good intention in trying to make something better. I think the reality is that we make it probably less clear. But I think clarity is something that will make healthcare work a lot better.
And I'm going to follow on that one. I was thinking about using the T word, but that might get me fired, transparency. But I'll take the clarity that you used and add to it responsibility, which is, I think, as you provide clarity to individuals as to what to expect, then there needs to be responsibility. And by that, what I mean is, if we all agree that you should be responsible for 10% of the cost of your care, then we all agree to that. And the idea that where we have now, which is if you drive your car in to get the oil changed, that should be the same for every similar car. Well, the problem is that who your payer is radically changes how much you pay in terms of healthcare. And so if we provide more clarity there, we also have to have some sort of common understanding of financial responsibility, so that way then we can have a common ground for conversation with both of those two in play. And that also, but Carlos first.
It also makes me think of like, but then also to say, of course, not every car is the same that goes into the mechanic. Mm-hmm. Clearly, the human body is much more complex. And so again, you bring in that question. So what may take $10 to accomplish, if you were to look at an itemized list of charges, for the next person, it could be 150 for the sake of having different conditions of their own personal health. So all that too.
All right, Carlos, I'll throw out the last question that kind of builds off of some of what you and Rodney were talking about toward the end before Q&A. We have sociology students tuning in tonight, public health students, political science students, students from all over campus, and maybe they leave this talk and say, gosh, what the kind of stuff that Carlos is working on is really interesting. And, I want to work on some of those issues. That's the kind of career that I'm passionate about. What's the one piece of advice that you would give some of our students as they approach graduation and they're looking ahead toward a career in politics and policymaking? Maybe it's in healthcare, maybe it's not.
Yeah, I would say be curious. If you're curious by nature and you just want to figure some things out, there's no better way than to actually go into this field and figure out from a policy standpoint, these are all the different sectors of the economy where government has a fingerprint on it, maybe a palm print or even a footprint for some people on it. And you really get an idea of seeing how systems or the bigger picture works. But then at the same time, you have to, in order to understand the bigger picture, you have to go down into the fundamentals of all the details and all the interconnecting points. And I think if you are interested in those types of things, then this is the right type of field or, occupation for you. I think also at the same time is that having an open mind. I don't have a career where I can tell you like I had it all plotted out. Mm-hmm. I didn't. I thought I did when I was a kid, and then you get older and things get complicated and you're like, yeah, actually, I don't want to do that. But that's okay. If you're figuring it out, it is okay. But the important part is that if you're doing something that you enjoy and you're passionate about it, everything else will flow after it. I think I've been fortunate and lucky to get to where I am today because I enjoyed what I was doing. And when you enjoy it, you're going to put a little bit more of the extra work into it. And if it's a little bit of extra work, you don't mind it because you're enjoying it. But then other things will come out of it. And I've somehow developed a career. And I'm in a spot where I'm talking to you all today. And the other personal stuff, I met my wife in this town. We got married. We had a family in this town. A lot of good things also come with it. So.
Well, thank you. And our students, I know, are appreciating all of these words of wisdom and the personal stories as well. So Rodney and Carlos, thanks so much for a really great conversation. There are a couple of questions from students that we didn't get to, so I'll get those on email. And Rodney, I'll shoot them your way. Thank you everyone else who joined us tonight for our NOKELive event. And we invite you to join us for upcoming events, including one this Friday entitled The Art of Your Story, to be held at noon this Friday, March 12th. Then on Thursday, March 25th at 4 p.m., we'll be live with the editorial and layout staff of the student newspaper, The Bracketiac, for a look at the paper's history and evolution. Also, for all of the alumni joining us tonight, Rodney, listen here. Please plan to attend Alumni Weekend Virtual Edition, April 15th through 17th. I've been told you will be amazed at the schedule of events the Alumni Office has planned, and for more information, please visit www.roanoke.edu/alumni. Take care, everyone, and stay well.